Good morning, everyone, and welcome to today's Vorys and Medical Management Group's webinar. Thank you for participating in our discussion today titled Healthcare Under the Biden-Harris Administration, the First 100 Days and Beyond. Before we begin, I would like to cover a few housekeeping items. At the bottom of your screen are multiple application widgets you can use. All of the widgets are resizable and movable, so please feel free to move them around and make the most out of your desktop space. If you have any questions during the webinar, you can submit them through the private Q&A widget without disturbance to the program. If you are having technical issues, you can find answers to common technical troubles located in the Help widget at the bottom of your screen, or you may submit a question via the Q&A widget. An on-demand version of the webinar will be available shortly after the program concludes and can be accessed using the same audience link that was sent to you earlier. Finally, as a reminder, this webinar is for general information purposes only and should not be regarded as legal advice. As always, you should contact your Vorys attorney if you would like more information or have questions about how these developments apply to your situation. Now for opening remarks and introductions, I would like to turn it over to today's speakers.
Ari, thanks so much for the introduction. Thank you, everybody, for joining us today. My name is Renee Nezikov. I am the Managing Director of our advisory services here at MMG. We really appreciate the opportunity to do this presentation with Lisa Mari and the Vorys folks. We hope you will get significant information about it and find it useful. Just a quick understanding of who we are for those that don't know about MMG. We are a physician service, managed service organization providing healthcare advisory services and revenue cycle management and practice management services to private and independent as well as hospital employed groups around the country. We provide both consulting and advisory services and focus really on the day-to-day operations of practices as we stated. As mentioned, I'm the Managing Director of our Healthcare Advisory Practice, been with MMG almost 20 years, focusing on our valuation, consulting, and for today's conversation, really will be around our operations and what we have seen in both our private practice groups as well as our employed hospital practices.
Hi, everyone. My name is Tamia Williams, and I've been with Medic Management Group since 2007. I'm a senior manager, and my main focus is providing operational support to medical practices and health systems. And I also perform general practice performance assessments and physician compensation modeling.
Excellent. Vorys, on the other hand, we are a full-service law firm with, as of recently, 8 offices across the U.S. Lisa and I are here specifically representing our healthcare industry group practice, and we work with providers really across the spectrum of the healthcare industry, from hospitals and health systems, nursing homes, long-term care facilities, to physicians, physician groups, home health agencies, ambulatory surgery centers, you name it. At some point, we've probably been involved, and we work with we deal with kind of the range of legal and regulatory issues that come up for our providers, as well as kind of the practical day-to-day operational implications of navigating those issues. Just to introduce your specific speakers today, we have Lisa Pierce-Rice, a partner in our Columbus office. As I mentioned, she is a member of our healthcare practice. And her practice particularly focuses on primarily health information technology issues, privacy and security issues, including under HIPAA and 42 CFR Part 2, breach response, implementation of electronic health records, and qualification for meaningful use incentives. I am Mari Mo. I'm an associate also in the healthcare group, currently based out of our Pittsburgh office. My practice includes both regulatory compliance, litigation, variety of components, and I particularly tend to focus on Medicare, Medicaid reimbursement issues and appeals, as well as behavioral health provider issues. And with that, I'll turn it back over to Renan to get us kicked off for today's topic.
Perfect. Thanks, Mari. So as Ari mentioned, even in our overhead is, we're going to be focusing a lot on what we've seen in the Biden Harris administration over the first 100 days, but we thought it would be important to do a little bit of a recap of 2020 from a healthcare perspective, what a crazy year we all just went through. Also touch base on a couple of items of the first few months of 2021 and what we're seeing, specifically around the Medicare changes for providers as it relates to coding revisions, coding updates, as well as the revised Medicare fee schedule as far as reimbursement and work RVUs. And then we'll finish up with just looking ahead of a couple of things that are in play for both 2021 and 2022. All right, so, where was our world pre-COVID? We've come a long way over the last 12, 15 months, but as a reminder, for everybody out there, January, February of 2020, unemployment was down to about 3.5%. Wage growth rate was around 4%. The whole industry as a whole was doing gangbusters. Travel and hospitality industry was really setting records. From a healthcare perspective, our volumes in our practices and as well as inpatient beds was almost at an all-time high. It was really hard to find good labor. Nursing staff, medical assistant staff was tough to find people. The job market was really strong. And as you can see from a Dow Jones perspective, we were just over 28,500 at that time. So what happened? And I think we've all gone through this, but again, as a good understanding, between March and June, we basically had a perfect storm really hit us. Essential services only from a healthcare perspective, really went from a busy practice and busy hospitals to really lack of beds and PPE. We were finding shortages across the board from oxygen and every other area. A lot of our specialty practices, especially those surgical areas within gastroenterology, those type of areas, were having to furlough staff, really stop doing anything else from elective surgical cases. Mari and Lisa are going to really talk a lot more on the telehealth focus, but we had this instant growth in telehealth. And for not just our private practices, but our hospitals and health systems and other healthcare industries, it was all about cash supply and what we could do. So we were trying to find ways to secure our PPP loans, Medicare advance payments, working with our banks for line of credits, significant changes from a cash perspective. And if you can see right at the beginning of middle of March, the Dow Jones, of course, went down to about 20,000, just over 20,000. But as we all know, where we're looking at today, there was a full rebound again from a Dow perspective.
So that brings us to our first poll question. What was the average decrease in hospital admissions and outpatient practice E&M visits in March through June 2020 compared to previous years? Please take the time to select your answer.
All right, so we have a very smart audience. You can see based on the results, about 67, 2/3 of you said about 65%, and a third of you was talking about 50%. So what was the actual recap and where we were? So you're 100% correct. Basically what we saw between hospital volumes and physician practice volumes, we saw anywhere between a 45 and 65, 70% decrease. Specifically around inpatient admissions, we were down about 45%. Majority of our hospitals in the ER visits were down 40%. Outpatient surgical volumes, as I mentioned earlier, were down anywhere between 60 and 70%. Again, really focusing mainly on elective surgical cases. Most other cases were deferred through the summer, and really even through the fall of 2020 to the winter of 2020, we were seeing some major catch-ups. From a outpatient perspective, what we were seeing the same idea from practice volumes. We saw our groups, not just ours, but you can see from this source under Crowe-Chizek that most E&M new visits were down about 60%, established visits down about 65%. Overall, according to the American Hospital Association, estimated about a 4-month financial impact of around $200 billion in losses on hospital industry. Around $50 billion a month was being lost. And as I mentioned earlier, we were all during this time focusing around our Medicare advanced payments, our HHS care subsidies, Part 1 and Part 2. We're still focusing on those and the repayment as those go along, and really what we could do from an overall cash perspective. I think as an overall, what we really learned in 2020, and I think, doing many of these webinars and changing again from being on site or being at clients working in their offices to working from home, we all realized our internet wasn't as fast as we thought it should be. We've all become really good at video conferencing, GoToMeeting, MS Teams, Zoom. All those type of platforms have really changed the way we're doing healthcare and the way we're all practicing today. For us personally and internally, we're doing a lot of blogs, LinkedIn articles, trying to still touch base with everybody, but from a remote perspective. And as I've mentioned more than once, but again, the concerns over debt, and then more important, the cash being king and running out of cash was a big focus for us.
So on just a little bit about the COVID-19 Accelerated and Advanced Payments Program. So on March 28th, 2020, CMS actually expanded that program, allowing providers and suppliers to apply to receive advanced payments because of the impact of COVID. On October 1st, 2020, they amended the repayment terms for providers and suppliers to lessen the impact of, paying the funds back. Repayment began on March 30th, 2021, depending on the 1-year anniversary of when providers and suppliers were issued their first cap payment. So as the repayment is laid out, such as payments will be recovered from Medicare payments due to providers and suppliers at a rate of 25% for a period of 11 months. After the initial 11-month recoupment period, the percentage at which cap payments are recovered will increase to 50% for a period of 6 months. Medicare administrative contractors will issue a demand letter after the 6-month period for repayment of any outstanding balances due. So there's a 11-month period, and a 6-month period and a 12-month period. So the repayment, the way it's laid out, will take 29 months. And after that, the demand letter is received, and any additional funds due will accrue an interest rate of 4%.
Thanks.
So this is Lisa, and I'm going to talk a little bit about the expansion of telehealth. As Ronan said, this has been an incredibly interesting year with regard to telehealth. Nothing like a pandemic to get folks who've been hesitating for years to jump right in. I likened it to somebody who was standing at the edge of a pool with their toe in, and then somebody came behind them and pushed them right in. And that's really kind of what we saw in 2020 with telehealth. If you look at the numbers, I think that bears out. Before the pandemic, McKinsey estimated the total annual revenue of all U.S. telehealth companies at $3 billion. And now, into 2021, a year later, $250 billion of the nation's health spend could eventually be digitalized. In 2020, McKinsey conducted a claims-based analysis, which found that 20% of emergency room visits could be avoided via virtual urgent care. 20% of office visits and outpatient volume could be done virtually, and another 9% could be done near virtually. Up to 35% of home health services could be virtualized, and 2% of all outpatient volume could be shifted to the home with technology-enabled medication administration. So I think we're literally just at the verge of what we're going to see with telehealth. And it's interesting from a technological perspective, much of this potential existed prior to the pandemic. As I said, we've been working with a number of our clients really for 5-10 years on what their telehealth plan was going to look like, what their contracts were going to look like, what their technology was going to look like. And it took really this, significant world event to get them really to push over into operationalizing it. So it's interesting. From technology, it was available, and it took the pandemic, though, I think, to get folks to buy in, because before that there were significant hurdles to both widespread adoption and normalization, both from a patient and a provider buy-in. I think everybody wondered what was the possibilities, and when you're forced to do it, you kind of find out what they are. About 57% of providers view telehealth more favorably now than they did pre-COVID. 64% are more comfortable using it, and this is according to a survey conducted in the middle of last year. So again, just months later, folks are getting there. And then 76% of consumers now report that they are interested in using telehealth moving forward. Remains between once you have the option, are you going to really use it or not? One other study I want to mention is Frost & Sullivan has forecasted a 7-fold increase in telehealth by 2025. The one thing, though, I just want to keep in mind, obviously there was this huge instant growth in telehealth last year because of the pandemic. I think that growth was bolstered by a number of the regulatory waivers that were given, both, HHS from a technology perspective and privacy perspective. A number of states had provided certain waivers for out-of-state physicians or bordering physicians. It'll be interesting when those waivers expire, again, how much of those initial barriers may be built back up. But I do think that we're going to continue to see this continued expansion and at least stabilization of telehealth being a normal part of the practice. I want to share a slide with you that I think is very interesting, and I want to give credit to Kyle Sharp, who is the Associate Executive Director of Specialty Care at the Ohio State University Wexner Medical Center. He and Ronan had presented a number of times before this, and he was nice enough to allow us to use this slide for this presentation as well. But again, if you look at the data from Ohio State, their own data, it shows the increase of telehealth in response to COVID. And they said, as of June 2020, they were seeing 90% of providers using telehealth as opposed to 2%, again, toe versus whole body in, and 2,500 visits per week versus the previous 100 per month. 13 million net revenue from telehealth activity is what they found. So again, this is just one provider that the numbers are astounding, really, in what happened last year. The other thing I want to mention about telehealth and some of the challenges are, and the changes we've seen are the interstate licensure issues that go with it. The rapid expansion of telehealth has brought with it a host of new and evolving issues related to interstate practice, and which is, again, the practice across state lines. Practice generally is deemed to occur where the patient is located. So that applicable regulatory body for that state has their jurisdiction. So if your patient's in Ohio, you're going to be looking at licensure in Ohio and what that means. Again, there are some compact issues. There are some state waivers at this point, but that will always be at least an issue that everyone's going to have to address when they're looking at their telehealth. Again, we've seen during COVID, Ohio has them as well, a number of state-level waivers designed to increase healthcare capacity. We expect those waivers will likely go away in some form, and folks are going to remain having to look at their licensure and make sure that they are licensed to practice in the state where the patient is. And again, some of those have already expired, so that's what we're telling our providers is, this is a great foray into telehealth, but just make sure you're really being aware of what waivers you have, what you're practicing based on, and when they expire. One other thing I want to mention was a December 2020 amendment to the PrEP Act declaration, which purports to give federal immunity from state licensing laws. it specifically states that healthcare personnel who are permitted to order and administer a covered countermeasure through telehealth in a state may do so for patients in another state so long as the healthcare personnel comply with the legal requirements of the state in which the personnel are permitted to order and administer the covered countermeasures by means of telehealth. It does not authorize otherwise unlicensed practice generally. So again, making sure that while we're practicing in this COVID mode, we don't start putting into place policies and procedures that frankly will violate laws going forward once this emergency ends. So it's just another good example. A couple more things on telehealth I want to mention. In addition to licensure requirements, it's important to keep in mind that telehealth practice, even with your state, may implicate various state and federal prescribing laws. For example, the federal Ryan-Haidt Act and many state laws restrict a prescriber's ability to write prescriptions for individuals on whom they have not conducted an in-person, on-hands examination. Again, that's one of the waiver areas that we've seen in Ohio was that initial exam was waived during COVID, but I expect that knowing the Ohio Medical Board, that waiver will likely go away, I bet soon. Similarly, for controlled substances, the DEA regulations typically require registration on a state-by-state basis. And again, many of these requirements are currently relaxed due to COVID. So just making sure that if you started telehealth during this time, you remain very aware of when those waivers are going to end. And the last thing I want to say about telehealth before we move to the next topic is, the intended takeaway here is that the telehealth practice will be is not going to be infeasible going forward. I think that there is, I think it's only going to expand. I just think it's going to everyone's going to have to adjust for what the new normal is going to be. But I think we are going to see this very much become much more of a norm part of, of pretty much everybody's practice. I think certain things will go back. I think, in addition to finding that we can do this, I think a number of providers have found things that don't work as well with telehealth, that they do really need that on-hands experience. I do think that in addition to the establishment of special registration processes that will help telehealth, like the Ryan-Haidt Act, I think we're going to continue to see expansion of interstate license compacts, like the nursing license compact, that someone can go get and practice across states that have adopted it. I think that's going to become more widespread. So again, I think we're going to continue to see a great deal of telehealth. It just is going to be a question of what that new norm is going to look like once all the COVID things go away. So with that, I'll turn it back to Ronan.
Thanks, Lisa. So, again, just a couple of additional items before we jump into where we see the administration and the healthcare is. I want to touch base on some coding changes as well as the reimbursement. And I think there are a lot of folks on the call with us who have a lot more experience than even myself on coding changes. But I wanted to remind everybody, we almost, just past 4 months into it, but there were significant changes that started January 1st of 2021 relating to how physicians and providers are supposed to be coding. There are about 8 main areas that I list below in the thing relating to history and exam requirements, time-based medical decision-making, things like that. And I'm just going to focus on 2 of those 8 areas. Again, it's hopefully something that everybody has spent time on, has had the education. It's something we at MMG are very comfortable with and happy to assist and help with in the conversation. But it has become an important change and decision-making for our providers. The 2 areas that I said I was going to focus on just from a high level is the history and exam, specifically around no longer being required to support the level of service. As you can notice through our slides here, it's really focusing on medical necessity. Who's performing it should be really all about documentation. We have been going through quite a few coding reviews for clients, some audits as well from governmental perspective. And it is, at the end of the day, it's all about the documentation supporting the services that are being provided. That we need to make sure that we're really focusing in those areas, or our providers are focusing in there. It's important to have the right templates, either being revised or ensure that there are set to be the documentation is focusing on what is actually being serviced. The reasons for the change in the history and exam, as I noticed in a note here, is the flexibility and how the visits are meant to be documented, as well as the elimination of the requirement for counseling or coordinating care to charge based on purely on time. The next one I wanted to touch base briefly on is, again, medical necessity. And Medicare and CMS has really made it clear that it is not the single overarching criteria for whether we're doing medical necessity or for the service that should be payable. And then just as a note, remember that while the concept of quantifying the MDM only applies to E&M services, at the end of the day, medical necessity is a concept that applies universally. So again, medical necessity is closely correlated with the nature of the problem addressed in the visit. It is really the focus on the visit. We're making sure, again, at the end of the day, that all documentation is being put in the right place. And then I just want to touch briefly on the reimbursement changes and work RVU. And just for a note, the proposed rule back in August of 2020 for the 2021 Medicare fee schedule had significant changes for both a work RVU and from an E&M perspective. And when we were doing our analysis and doing a lot of data work for our clients, we were really expecting significant gaps between what we expected to be reimbursed and what we expected to see from a work RVU change. So what was happening is that the same E&M code, for example, a level 3 visit or a level 4 new visit, the attached work RVUs for those services was going to go up dramatically, almost by 11 to 12%. But the reimbursement for that same service as what it was in 2020 was either going to basically stay level or actually decrease a little bit. So there were, for a lot of our groups and practices, especially in the hospital side who are employed, that have provider or productivity-based compensation agreements, which basically tells us that they get paid by the work RVU, was going to see some significant changes or differentials on the number of work RVUs being produced, but the collections for those same services that they needed to pay our providers. So there was going to be these huge gaps. Well, what happened is when the final rule was published in December 2nd, there were significant adjustments to that proposed rule, which allocated majority of the differential and the fee changes to take away that differential, as well as the sequestration that was supposed to end on March 31st. I think a couple of us had gone through that, delayed the complexity add-on codes through 2024, as well as delayed the 2% sequestration, so that as of April 1st, we are still getting reimbursed at the full normal rates for 2021, but that is meant to end, and it goes through December 31st, 2021. So one of the things that we're going to have to be keeping notice on or care for is what does 2022 look like? We can, as of right now, if there are no changes within Congress, we will again have the significant decreases in our reimbursement, but could see some significant increases in the work RVU. So at the end of the day, again, just want to reiterate, we did see basically where our reimbursement was matching our work RVUs. It wasn't as big a hit as that we were expecting to take, but did definitely have some effects for us overall.
So that brings us to a couple more poll questions. The first poll question is displayed on your screen. And approximately what percentage of your employees are working remotely or on site? Okay. Wow, a lot of our clients here at, that we work with are a lot of medical practices. So, they're all working, on site. There are very few who have allowed some of their business office staff to work remotely. But it's nice to see that there is somewhat of a mixture. Looks like about 54.5% are working 100% remotely, and 27%, about 50% remotely, and 18.2% working on site. It's a good mix. Our next poll question. Let's see. So you or your employer have set a date that you will be coming back to the office. That's what we are finding for a lot of the bigger organizations who have allowed their staff to work remotely have not really determined a return to the office date. So. All right, so we wanted to, just touch briefly on a few practice operation items. We'll take a deeper dive in the second webinar of this series, but some of the things that we are encouraging our clients to do is to keep the COVID-19 office policies and procedures up to date. We find that it's better to, over communicate with employees and patients. That keeps them in the loop of what's going on. Some of the items to consider when you're thinking about your policies and procedures, will and should you continue your screening protocols in the office? As more people are getting vaccinated, that question is, coming up a lot. Do I have to, keep taking my temperature as I, come into the workplace? Do we have to take all patient temperatures as they enter the building? Should social distancing requirements continue to be enforced? I know a lot of our clients are only allowing patients to come in for their appointment unless it's absolutely necessary that they have someone with them. Will patients be allowed to have someone accompany them? That's one of the biggest things. That's where a lot of our practices have received some pushback. A lot of older patients like to have someone with them at their appointments. The next item to consider is, will the medical practice continue to enforce that all employees, patients continue to wear a mask even after vaccination? A lot of our clients are already receiving that question. I received my vaccination. Do I have to, continue to wear my mask? Can medical practices mandate employees to get vaccinated? That is a big one, and we'll definitely take a deeper dive in the second webinar. But those are some of the things to start thinking about. Does the medical practice have a travel policy for employees? There's a mix with our clients. Some are just following the, state of Ohio guidelines, and some have chosen, not to, really have an internal policy. Last but, not least, will the medical practice voluntarily continue to offer the FFCRA leave for employees through September 30th, 2020? And again, with our clients, there's a mix. There's some who've stopped at the end of March 2021, and then there's some who have continued to voluntarily offer it through September 30th, 2021. So as always, just continue to keep employees and patients informed policy changes. So the, CDC released some guidelines regarding fully vaccinated people on what they, can do. That was released on March 18th of 21. So fully vaccinated people can gather indoors with other fully vaccinated people without wearing a mask or staying 6 feet apart. Gathering indoors with unvaccinated people of any age from one other household without a mask or staying 6 feet apart. So an example of that would just be visiting with relatives who all live together. No prior testing to travel or self-quarantining after travel within the United States. International travel, you need to pay close attention to the situation at your international destination before traveling outside the United States. You do not need to get tested before leaving the United States unless your destination requires it. You still need to show a negative test result or documentation of recovery from COVID-19 before boarding a flight to the United States. You should still get tested 3 to 5 days after international travel. You do not need to self-quarantine after arriving in the United States. If you've been around someone who has COVID-19, you do not need to stay away from others or get tested unless you have symptoms. However, if you live in a group setting, and are around someone who has COVID-19, you should still stay away from others for 14 days and get tested, even if you don't have symptoms.
Okay, so I think with that, we thought actually getting into what we're seeing from the Biden-Harris administration, what we thought the first 100 days are going to look like, especially as we've just hit basically this last week was day 100, some of our ideas and what we've found. So with that, I'll pass it on to Lisa and Mari.
Thanks, Renan. So one of the first kind of highlights of the first 100 days obviously has been the pandemic response. It's kind of what's on everybody's mind and has been for the past year, as has been the predominant theme of our presentation so far. We have seen kind of some shifts and developments in how the government is responding to the pandemic with the new administration. Public health emergency declaration was renewed effective April 21st, and that was starting to become an increasingly politicized issue towards the end of last year. Now, HHS has basically stated its position that the public health emergency will likely remain in place for the entirety of 2021. It's only technically extended for 90 days at a time, so as of now through July 20th. But HHS has indicated that it will give 60 days notice, at least to state governors, if the decision is made to terminate the public health emergency or allow it to expire. And this is significant because, as we've alluded to earlier, there are a number of waivers and other provisions that are in place only for the duration of the public health emergency. That includes emergency use authorizations, a lot of the regulatory waivers that we've touched on, for example, under HIPAA or the DEA regulations. So it's an important kind of deadline to keep an eye on. It's very helpful to know that we will have some notice now, hopefully before it goes away. The other big theme of the first 100 days in the COVID context has been vaccinations, of course. The original goal stated by the Biden administration was 100 million vaccinations in 100 days, and that was reached on day 59. So our kind of initial rollout was well ahead of the pace that we originally anticipated. But we've now seen kind of a slowdown as most of the population who is interested in getting a vaccine, who's willing to get a vaccine, has now received one. So the new goal as of this week is at least one shot to 70% of the adult population by July 4th, and a full vaccine regimen, meaning either 2 doses of the Pfizer or Moderna vaccines or 1 dose of Johnson & Johnson, to 160 million Americans. So based on the difference between where we are now and that goal, it's about the same pace as the original 100 million goal, which is about half the pace of the second 100 million as it actually played out. So that goal is recognizing that we've had a little bit of slowdown in distribution, and the administration is looking to combat that by winding down mass vaccination sites, concentrating on smaller clinics and mobile sites, particularly in rural areas, and accelerating a public relations campaign to boost vaccine confidence. So for providers, for our clients, one of the big issues that they've been thinking about in connection with vaccines, what kind of liability exposure they might have, and it's been kind of particularly brought to the forefront with the recent pause in the use of the Johnson & Johnson vaccine. So there have been a number of amendments to the PrEP Act declaration since the Biden administration took control that authorize additional categories of qualified persons to prescribe, dispense, and administer covered countermeasures. We've seen some of those categories defer to state law determinations as far as who is authorized to administer a vaccine, what kind of supervision has to be in place for the particular types of practitioners to be able to administer vaccines. So we've seen a little bit of confusion there, but as we are winding down mass vaccination sites, we'd expect to see providers getting a little bit more comfortable with their policies and procedures for administration. We've also seen some changes in federal policy regarding the availability of compensation for vaccine injuries. Notably, the COVID vaccine is actually, injuries resulting from the COVID vaccine would actually fall under the Countermeasures Injury Compensation Program, which is administered by HRSA, rather than the National Vaccine Injury Compensation Program, which covers most more familiar, more established vaccines. So that's significant because the National Vaccine Injury Compensation Program is much more well established. The case law around that is a lot clearer. There are a lot of questions still around how exactly the Countermeasures Injury Compensation Program is going to be administered. It has rejected 90% of vaccine injury claims over the past decade, which is potentially concerning both for recipients of the vaccine and also for providers, because if compensation is not available through this designated program, it creates more of an incentive for individuals who may have suffered some kind of harm as a result of vaccine administration to seek recourse from the provider. So there's been some changes in terms of what injuries are compensable under the National Vaccine Injury Compensation Program that, while not directly applicable to the COVID-19 vaccine, have been kind of concerning initially to the public. They sort of send the wrong message at a time when we're really trying to encourage people to go out and get vaccinated. Specifically, the Trump administration in its last few weeks took the position that certain shoulder injuries, which are the most common type of vaccine injuries, would not be considered compensable going forward. As part of its kind of public relations campaign, the Biden administration delayed that rule and ultimately rescinded it on April 21st. So really trying to encourage people to go ahead and get vaccinated despite the risks that have really been brought to the forefront with the pause of the J&J vaccine. So takeaways we've been discussing with our provider clients are that you really want to have a robust release or liability waiver in place when you're administering vaccines, not just rely on the immunity that purports to be available under the PrEP Act or the availability of compensation under the Countermeasures Injury Compensation Program. Those are really kind of untested, and we do expect to see plaintiffs getting a little bit creative, particularly the more compensation is restricted as these programs actually start to play out. Also, it's important, as we've mentioned a few times today already, to carefully and continuously review your administration procedures. We expect that the availability of PrEP Act immunity will, at least to some extent, depend on careful compliance with the restrictions as far as what types of practitioners, what types of licensees are able to administer vaccines, as well as the requirements of the applicable emergency use authorizations, which are a little bit different for each vaccine and have been at least periodically updated. We expect that will continue. Another kind of highlight or theme of our first 100 days has been ongoing efforts to address the opioid crisis. We've really seen kind of an interaction, an exacerbation of the opioid crisis as a result of the COVID-19 pandemic, both as a result of social isolation, anxiety and depression that so many people are experiencing, but also some of the regulatory waivers and flexibilities that have been extended throughout the COVID-19 pandemic has made it easier to get hold of certain prescription drugs that are prone to abuse. In response, we've seen a number of changes in policy and some requests for funding. For example, the Office of National Drug Control Policy published a statement of priorities for year one that indicated it will be examining kind of the legal and regulatory requirements that are currently in place, applicable to providers of substance use disorder treatment services, in particular medication-assisted treatment. They're proposing changes to try to streamline that process, make it a little bit easier for providers to get into this treatment space and hopefully increase capacity. In its very last week, the Trump administration had previously published a document called Practice Guidelines for the Administration of Buprenorphine, which would have eliminated what's known as the X waiver requirement for DEA-registered physicians to prescribe buprenorphine for medication-assisted treatment. This was withdrawn pretty quickly once the Biden administration took office. It was recently replaced on April 27th with new guidelines that are both broader and narrower in that they apply to not just physicians, but all qualified practitioners under the DEA registration scheme, which includes physician assistants, nurse practitioners, et cetera. And instead of eliminating the X waiver requirement entirely, it eliminates certain certification requirements that were previously in place to obtain that waiver. So it makes it a little bit easier to do without removing the requirement that you get the waiver altogether. As I mentioned, there's also additional funding provided under the American Rescue Plan Act, and the Biden administration's budget request for 2021 seeks an additional $10.7 billion to help combat the opioid crisis, which would be a 57% increase from last year's levels.
Great. So
I'll
just jump in there. I think, we just got about 15 minutes, so we still got a couple of things we want to cover. So clearly one of the main focuses as well within the new administration is what we expect to see with the ACA or the Affordable Care Act. And of course, with President Biden, very much with President Obama was to restore Obamacare to a significant amount of, based on the prior administration really focusing on really ending a little bit of ACA and where it was going to be. So you will expect to see, and we have been seeing this new administration trying to protect and restore as much as possible. Where the focus is on the enrollment in the marketplace. We saw literally within these first few days of taking over the administration, President Biden put in a couple of executive orders specifically around the way to expand access, I should say, on the ACA coverage. You can see actually on the enrollment with the healthcare.gov website, started back on February 15th. It is supposedly to go through May 15th, so in basically another week. And the focus is really trying to get, as I mentioned, additional coverage for a majority of Americans. The expectation is around 10 million additional U.S. citizens will be signed up, Americans will be signed up under the ACA changes. We'll wait to see exactly what the final numbers look like. There's been a couple of additional memorandums on who is going to be focused under the ACA. Focused on that was really around protecting women's health, and then also access to comprehensive reproductive health care. We're going to see exactly, what the possible financial impact will be on our practices and on the health system as a whole. but definitely this will be one and is one of the main focuses of the administration to bolster the ability for citizens, for Americans to access healthcare through the ACA program. We're starting to see a little bit of a bump or increase in our payer mix, to see where patients are, if they are signing up. And again, I think this will be an interesting conversation in the next, in 30 days' time, post this May 15th deadline, to see how effective the additional enrollment really was.
So I'm going to jump back in and talk about one of everybody's favorite topics, which is always enforcement. And the Biden administration, in addition to all they have talked about, has promised basically there is going to be robust enforcement again. As we've alluded to a few times through the presentation, we are expecting enforcement activity in a number of different contexts as regulators return to normal following the pandemic. And we wanted to touch on just a couple of those areas that we think we're going to see. The first is price transparency. Because the hospital price transparency rule took effect on January 1, 2021, it is not subject to the regulatory freeze President Biden imposed when he took office. I guess timing is everything. In addition, new Health and Human Services Secretary Xavier Becerra's Senate confirmation hearing specifically addressed his commitment to enforce price transparency initiatives. So, that is right at the top of his list. And then one other point I want to make is Turquoise Health reports that a third of the 6,000 hospitals evaluated had 4 to 5 star compliance. IBM Watson reports compliance rates significantly lower, as like 2 of 17 hospitals in compliance. So, again, I think the reports are all over the board, which may lead again to more at least looking under the hood to see what's there and what's not. The second area that we're seeing, I think probably some increased enforcement risk is fraud. And obviously that's one of the key themes everybody in the healthcare industry is always sort of in the back of their mind as we're all making decisions. I want to note that our new Secretary Becerra is not a physician, but he's a former attorney general with a history of aggressive fraud prosecution. So again, just something to keep in mind as we just look at the change in administration. The Department of Justice Civil Division has indicated that its specific enforcement priorities under the Federal False Claims Act include 1, pandemic-related fraud, 2, EHRs. For example, the United States recently alleged that CareCloud violated the False Claims Act and the anti-kickback statute through its marketing referral program called the Champions Program. In particular, it alleged that between January 2012 and March 31st, 2017, CareCloud offered and provided its existing clients cash equivalent credits, cash bonuses, and percentage success payments to recommend CareCloud's EHR products to prospective clients. Existing clients who participated in the Champions program executed written agreements prohibiting them from providing negative information about CareCloud's EHR products to prospective clients. Prospective clients were not told about this referral kickback arrangement or about the contract that prohibited the sharing of negative company information with them. So the U.S. has alleged that CareCloud's payments to participants violated the federal anti-kickback statute. And they allege that CareCloud violated the False Claims Act because the kickback payments rendered the claims submitted by CareCloud to be potentially fraudulent. So, again, it's one of those things as we're all looking at arrangements and moving forward. And there's so many tech provisions, I think, and arrangements that can be done. We always have to keep, I think, the anti-kickback statute, the Stark rules, and the ensuing applicability of the False Claims Act in mind as we're doing that, as I know we all do. The other 2 things I want to mention on the priorities list are telehealth fraud and cybersecurity fraud. HHS has said that telehealth and COVID-19 audits have also been added to the OIG work plan for the coming year. And I also want to note that regulators are increasingly using data analysis, and we all know it. There's a ton of data out there, They're using it to identify targets, meaning that any outliers in your data, and the biggest one is when you have somebody billing 36 hours in a 24-hour day, red flag. So it's those kind of data analysis that can really get you into trouble and make you a target. So just being aware.
Perfect. I appreciate that, Lisa. So one of the areas, that also I think is a big focus around the administration right now is around drug pricing. And it's actually one of the real true areas where both the Trump administration, prior administration, and what we're seeing right now currently from the Biden-Harris administration really are actually on the same point. And that is that taking on basically the big pharma, where we are with drug pricing. For those that remembered, during the Trump administration, he had put some executive orders around most favored nations. And what the most favored nations basically said is that all drug pricing will be based on the lowest cost of 7 or 8 international pricing of what other 7 or 8 international countries were paying for the same drugs. Currently, that is sitting in the courts. There's a lot of restraining orders around that. Major impact for sure was going to be around the oncology and urology space. But what we are seeing is that, for the most part, the Biden administration, I think, will take the mantle from what was done in the prior administration and run with this, continue to see and focus on drug pricing, on a little bit on relating to price transparency that goes along with it, and really having a major impact. What we did see is that drug pricing measures are continuously conspicuous on the American Families Plan that was just discussed. And then my note here, you can see literally last week and in the first address to Congress on April 28th, President Biden really did ask Congress to allow Medicare to negotiate prescription drug prices. So there's definitely a focus in the administration around drug pricing to curtail the price of where we think things are going to be. Again, a huge impact on, as I mentioned, the oncology, urology space that we do a lot of work in. There's a lot of concern of what that's going to look like. And I think more to come shortly from there. As you can imagine, there's a lot of opposition by the pharmaceutical industry on this. But I think there will be some final passage. Again, it'll hopefully see what the courts decide as we continue to look at this. So I definitely recommend for all those groups that do use a lot of drug pricing, that use a lot of J codes, definitely keep an eye on this, something that between MMG and Vorys, we'd be happy to continue that conversation to help navigate through this.
Great. A couple left, but we wanted to touch on just a couple quick items that we are going to be looking out for in the coming months to continue into the year. First is provider relief fund reporting. We talked a lot about the importance of provider relief funds in sustaining our provider clients over the past year and a half or so. Provider relief fund reporting has been expected for a while now, but the initial deadline of February 15th was delayed indefinitely. As of now, the quote-unquote final report is due July 31st, 2021, quotes because, of course, there was no actually additional initial report as was originally contemplated under HHS guidance. So this will be the first time that the obligation to return any overpayments of provider relief funds monies comes into play. So that will be a significant area of exposure for a lot of providers. Also, we recently saw the release of the 2022 Inpatient Prospective Payment System proposed rule. A couple of noteworthy provisions are that it proposed to extend add-on payments for new COVID-19 treatments. It also proposed a 2.8% payment increase for hospitals that successfully participate in the hospital and patient quality reporting program and are meaningful EHR users. There are a couple of expanded or changed reporting requirements that go along with that to be able to be eligible for that payment increase. But I would encourage you to take a look at that if it is applicable to your particular provider type, and comments are due by June 28th, 2021. So thank you all so much for your time. I think that's all we have for today, but I would just invite you to reach out if you have any additional questions to any of today's speakers. Our contact information is available for you on this slide. Thank you so much again for joining us.